Today we are tackling endometriosis. We are going to talk about endometriosis in detail. Endometriosis, personally, it's one of the most devastating conditions I've had to deal with as a clinician. It's quite a sensitive topic because some of its effects are quite detrimental. So with me is Dr. Kyra Anthony. Dr. Kyra Anthony is an obstetrician and gynecologist, also a clinical embryologist. We are glad to have you.
Thank you.
Yes. So first things first, Dr. Anthony, what's endometriosis?
So many of our viewers may have not heard the term before, or have heard the term before, but are not so sure what it exactly means. But let me take you back a bit. If you look, every lady, most ladies out there go through their menstrual cycles. Menstrual cycles is when you have a scheduled bleed with every after a month or a bit of few more days more. Now, during the period of that scheduled bleed, the lining of the womb, so the womb is the uterus. The uterus has a lining. That lining is shed in the form of blood that you see as a scheduled bleed that happens repeatedly every month. That is what would be expected in a normal situation. In endometriosis, that lining is not only found within the uterus. That lining is also found in other areas of your abdomen outside of your uterus. So what happens is that this lining that is outside your uterus, when you go through the scheduled bleed and you have blood from your uterus, even this lining outside the uterus will bleed. The unfortunate bit is that when it is outside the uterus, it's not in its normal location. And the blood that is released from that lining outside the uterus will not move out of the body. So, being in an abnormal location, the body will react to this lining and the blood that comes from the shedding that is scheduled from this lining. Eventually, you will have the endometriosis disease start to grow. So, in summary, endometriosis is when you have the lining of the womb developing outside the womb in other areas of the body where it shouldn't naturally exist.
Okay. Thank you, Doc. So where else can it go apart from it being in the womb?
So, looking at the abdomen, you can find the lining on the fallopian tubes. These are the tubes where the eggs and sperm meet. Okay. You can find it on the ovaries. You can find it on the intestines. Okay. You can find it on the diaphragm, which is like that muscle that is just below your lungs that helps you breathe. Mm-hmm. You can even find it in the lungs. Endometriosis has been found in so many areas of the body, even outside at the cervix, in the vagina, inside the rectum. It can be found anywhere, but as long as it is outside the womb, it's endometriosis.
Okay. So how common is this condition? How common is endometriosis?
Of course, we mainly know data that is from countries that tend to collect this information in their demographic databases. But what is estimated is that 1 out of 10 women is suffering from endometriosis. And among these women, if they have an experience of pain, that is painful periods, pain on having sex, some kind of pain that is long-standing, then there is a 40 to 60% chance that they have endometriosis. If you're looking at a group of women who have pain and are also having challenges having children, there's a 70% chance that one of them has endometriosis.
Okay. So what are the common symptoms? What are the common signs that someone looks out for?
The commonest symptom of endometriosis is painful periods. Unfortunately, we tend to take this for granted. I know in our traditional society, women have been kind of raised to accept that pain is normal, but it is not normal. Okay. And any woman out there who has painful periods should have an evaluation. because among those with painful periods, 40 to 60% of them may have endometriosis. So the commonest symptom is painful periods, and it can be any kind of pain, sharp, dull, throbbing, burning, any kind of pain. But this is pain that is long-standing. Sometimes people may report pain that starts from the first period they ever had when they were young, and every cycle it is painful. And it can range from pain that is bearable to pain that requires medication that is oral, or pain that may require injections. Some people even do not go to work because of this pain. So I believe there's a lot to tackle in terms of does painful menses warrant sick days off work? Because people underestimate what painful menses are. But one of the most common symptoms is painful periods.
Okay.
The next one is people will report at varying degrees painful sex. Not all of people with endometriosis will have painful sex, but some will report that they have pain ever since they began having sex. They've always had significant pain.
Okay.
And some others will develop the pain over time.
Okay.
Then, depending on where the endometriosis is, remember we talked about the lining being outside the womb?
Yes.
It can be on the ovaries, it can be on the intestines, it can be in the rectum, it can be on a urinary bladder. So, if for some people where the lining is in the urinary bladder, they may report that every time I have my menses, I also have blood in my urine. Every time I have my menses, I feel so much pain passing stool, and I might have blood passing stool. For the very few patients I have seen, there are even those when they have their menses, they get cough, difficulty in breathing, and they might even cough sputum with blood. Okay. So wherever the lining is, it's likely to also go through the same changes as the normal lining in a menstrual cycle.
Yes. Okay. Personally, I've actually seen endometriosis presenting even what we call cyclic bleeding from the umbilical cord.
Yeah.
In case endometriosis is present on the umbilicus.
That is very true.
Okay. Yes. So, we've said we can find endometriosis in the lungs, we can find it. Recently, there are cases where they have even found it in the brain.
Yes.
So, I'm looking at the uterus with its inner endometrium. How does this endometrium go to distant places like the lungs? What's the explanation behind it?
Yeah. There is a lot of research that is going in there.
Okay.
There are theories, we call them theories, because it's very hard to determine. Once endometriosis is one of those things you find first, then you think, how did it get here? Okay. It's very hard to follow up someone closely to see what exactly happens. But from various studies, there are certain theories that have been come up. One of them is that the lining of the womb and the uterus develops from the lining or has the same properties as the lining of the abdomen. The abdomen is, what people call a stomach. Yes. All this, when you touch your belly, underneath your belly, that's your abdomen. And your abdomen has a lining. And during development in your mother's womb, in the very early stages of life, the lining of the womb and the lining that is of the abdomen come from the same tissue.
Yes.
So, in some theories, it is believed that since the lining of the womb has the same properties as the lining of the abdomen, then maybe the lining of the abdomen can also start to develop into a tissue like the lining of the womb.
Yes.
Such that in areas within your abdomen, your tissues transform to become like the lining of the womb, and they start going through cyclic changes.
Okay.
But unfortunately, that is still an abnormal position, and there will be consequences for that. In another theory, during the menstrual bleeding, since the uterus and the fallopian tubes and the cervix is a complete tube, the entries through the cervix, uterus, fallopian tubes into the abdomen.
Yes.
So as blood may go down through the cervix and it is seen in the vagina, blood can also go backwards through the fallopian tubes into the abdomen. Yes. And there is a belief that part of why some people have endometriosis is because there is that reverse or backflow of blood. And the blood lands there with some cells of the lining of the womb, and then they implant and start to grow. Then thirdly, there is also a theory that some of the cells that are lining the womb may enter the blood into blood vessels and may be taken to distant sites away from the womb, where they will settle, implant, and result into an endometriosis spot. So these are theories. It's hard to pinpoint which one of them is causing endometriosis in a particular patient, but that is what the research has shown as per now.
Okay. Is there a genetic predisposition to it?
Yes, there is a genetic predisposition. As you can see, the chance that someone's lining of the abdomen will transform, the chance that someone's blood will backflow, the chance that someone will have cells getting into the bloodstream and being taken to distant sites. There's always a level of the abnormality somewhere, which could be genetic, but now being seen by the occurrence of endometriosis. So there is a genetic predisposition, but there's so many genes that have been studied. There's not one gene that says if your mother had, you'll have, not exactly. So what we believe is that what happens in your womb in your mother's womb is that you get some kind of predisposition. Then something happens in the environment, either something you're exposed to or some drugs or some chemicals that makes endometriosis eventually manifest. Yes.
So personally, I've had interaction with patients with endometriosis, and it's very unfortunate that most of the time when you diagnose the disease, you find it in its late stages. We shall talk about the staging. Why is it so hard to diagnose? Why is it diagnosed so late?
One of the reasons is what I mentioned earlier. You see, in our kind of society, we've kind of encouraged women to bear pain. Not just endometriosis pain. Even labor pain has been normalized as you need to go through it to be a woman. So you find very many patients who say, and even friends who say, even if I have pains in my periods, I won't take anything. I'll bear. So in a way, that has led the society downplaying painful periods. You see that, eh? So painful periods are downplayed. By the time someone walks into your office to say, I have this problem of pain in my periods that has been on for years, it has become unbearable to the point that they cannot continue to downplay it. But society kind of enforces that even a woman can't get a day off because of painful periods. They say, how do you get a day off? I'm sure very many companies out there and many HRs will never accept the excuse of painful periods. But it's real. It's very real. But that society kind of notion right now that has normalized that periods should be painful and that whoever can't deal with them is weak, is why people take so long to report to the office.
Okay. So how do you diagnose it? Does a simple pelvic scan pick it out? Are you able to tell?
So one of the biggest things is the index of suspicion. As you say, common symptom, painful periods for a long time. Sometimes the history alone is enough to know this woman has endometriosis. For example, she has painful periods, she has painful sex, She also has issues with getting a child. You are really highly suspicious. But if you want to really determine that this person has endometriosis, there's what we call a diagnostic laparoscopy or a camera test. Or some people call it keyhole, a diagnostic keyhole camera test. This is when the doctor, after appropriate preparation, will introduce a camera into the abdomen and will be able to visualize directly if there's any endometriosis. As we mentioned earlier, these are spots in your body which resemble the lining of the womb. And they might have gone through some kind of transformation, but the knowledgeable eye of the doctor will be able to detect if this is there. An ultrasound scan in the right hands and with a high index of suspicion can be able to detect what could be endometriosis. But the gold standard is to have a keyhole test or a camera test done to see the lesions take off some tissues. So an ultrasound scan in the right hands with a high index of suspicion can detect, but as you see, the ultrasound scan is limited. It will mainly detect more severe forms of the disease than very early forms.
Yes.
So diagnostic laparoscopy or a key camera test is the gold standard, but the fact that you cannot afford a laparoscopy doesn't mean you can't have an endometriosis diagnosis. So your doctor having a high index of suspicion can actually treat you for endometriosis before you have a laparoscopy done.
Okay. So you as a fertility specialist, I'm sure you've interacted with these patients. First of all, does endometriosis affect fertility?
Yes, it does.
How?
So I think we will probably bring up this degrees of endometriosis. So
Yes.
endometriosis has 4 stages.
Yes.
Stage 1, stage 2, stage 3, and stage 4. And all these are measured in the degree in which the endometriosis is affecting your reproductive organs. Are you having scars around your tubes? Are you having scars on your ovaries? Are you having collections of blood within your ovaries? Are you having scars behind your uterus? Are you having scars that join your intestines and your womb? So in stage 1 and stage 2, the scars are not so many. Your fallopian tubes are still moving freely, and there is no involvement of your ovaries. So you can have the eggs picked up every month, and there's a high chance of no problem with fertility. Indeed, stage 1 and stage 2 is called mild or minimal disease.
Okay.
There is usually no effect on fertility. They tend to get pregnant just like anyone else who's trying to get pregnant without a problem. But stage 3 and stage 4, which is moderate and severe disease, there's more involvement of the fallopian tubes by scar tissue, more involvement of the ovaries by scar tissue. There's likely to have collections of blood within the ovaries or involvement of scar tissue behind the uterus connecting with the intestines. This kind of situation makes it very difficult for the egg to be picked within the ovulatory period of the month. As such, people with stage 3, stage 4, which is moderate to severe disease, will have challenges having children. So in a way, endometriosis affects fertility, but in its most moderate and severe forms.
Okay. So in the moderate and severe forms, are these patients limited to assisted reproduction?
No.
Okay.
So in moderate and severe forms, the only way conception can be achieved is by assisted reproductive technology. That is the IVF, or as some people may call the test tube baby. Because the main reason for this technology is to try and do the role of the fallopian tubes. That is, collect the egg, collect the sperm, conduct fertilization, create an embryo, put it in the womb. That's the role of fallopian tubes. And with endometriosis affecting fallopian tubes the way in the moderate and severe forms, you expect the tubes not to be functional.
Okay.
So IVF, unfortunately, is the only way people with stage 3, stage 4 disease can actually conceive.
Okay. So talking of IVF, endometriosis, what are the chances of a recurrent implantation failure and the success of the IVF itself?
Yeah. So with IVF and endometriosis, and one thing maybe I could bring up is endometriosis has a very close cousin that is too big a topic to cover today, called adenomyosis. You see, as we mentioned, that the lining of the womb outside the body, outside the uterus, the lining can also be in the muscle of the uterus, where still bleeding occurs and the blood goes nowhere, so the body reacts to that. And this condition usually closely either happens alongside endometriosis or over time will happen in a patient who has endometriosis. And in this kind of condition, we have seen significant challenges with IVF success. So it's not uncommon that someone with endometriosis might have several cycles without success.
Okay.
And another thing is with people with stage 3 and stage 4, we talked about involvement of the ovaries.
Yes.
And those involvement of the ovaries by the endometriosis may damage ovarian tissue. By damaging ovarian tissue, you have a loss of eggs. So your doctor does stimulation on you, but the eggs are always very few, and the fertilization is not so good, and hence the implantation rates are not so good. So
Okay.
the chances of pregnancy through IVF for, I would say, a person who has clear issues with the tubes, that's why they're doing IVF. And a person who has endometriosis, that's why they're doing IVF. The person with just blocked tubes, no endometriosis, has a better chance of success. That doesn't mean that people with endometriosis don't conceive, because many of them still do conceive with IVF.
Okay. So we've talked about the disease. I mean, what are the treatment options, and does the disease cure?
So, unfortunately, endometriosis cannot be cured, but it can be managed.
Okay.
And it's managed according to the goals. Sometimes what's bringing you to the clinician is pain,
Okay.
sometimes getting a child. And with pain, surgery is an option, because the attempt with surgery is to remove all places and spots where the disease is located. And because we assume that where the disease is, it's what's causing the pain. So when you undergo surgery and you have most of the disease removed, you can have a better quality of life, reduced pain.
Okay.
But endometriosis has been known to be notorious in recurring. So over time, 2 years, 3 years, it tends to recur. If it's about getting a child and the doctor says you have severe or moderate disease, that's an IVF. So depending on why you're seeing the doctor, and the goals should be very clear with your clinician, that am I managing pain? Because there's a whole different ballgame there. There's some injections that you can receive to kind of suppress the disease. There's certain pills you can take to suppress the disease. But most of these treatments for pain prevent you from getting pregnant. So if someone is needing to get pregnant but they have pain, you may need to prioritize
Yes.
getting them pregnant. Because if you put them on some of these treatments, they will not be able to conceive. So it's a bit of a mixed bag. Sometimes you have to really get a balance between whether you need to really manage the pain or prioritize conception for the patient. So the goals are made in shared kind of manner with your clinician to kind of prioritize what you think needs to be addressed first.
Yeah.
And then that's really how the management goes.
Okay. So it's really quite devastating, because you're looking at someone with endometriosis. They are already suffering this chronic pain. They have failed to conceive. Some of them, marriages have broken down. These patients are most of the time depressed. Personally, the ones I've interacted with, some even break down in office. I mean, what's your personal experience treating these kind of patients?
I believe it's one of the conditions. I actually usually used to tell myself that if I die and I end up, luckily enough, at the pearly gates of St. Peter, I'm going to ask God, why endometriosis? Because it's one condition that's quite a mystery how it originates, but creates so much havoc in the life of not only the one who has it, but those around them. You know, the pain is not just felt by the person who has endometriosis, it's felt by their partner, by their brother, by their mother, by their society, by even the organization where they work, because there's a days of work. So it kind of creates a big impact in the whole community. But for the patient, it's the worst thing ever, because endometriosis is not something you wear on your face. Endometriosis is not something you look at someone and say, has endometriosis. No, you can't. You can't see endometriosis. It's a silent plague that is destroying this woman's life and her family and her most close community. But she can't speak and be seen. It's one of those things that people really need to appreciate, that it's quite disastrous for these patients. The pain is impossible. If someone, one time a lady described to me that she felt like her bones were being broken, put back, broken, put back, broken, and put back. And then one patient told me when she was having sex, it was like her husband was just putting razor blades into her vagina. That's what it felt like. So I can only, as a third party, appreciate this, but as men, we can never really appreciate what this pain feels like. But we need to show deepest concern in addressing it, because these people need our help. Indeed, most times the consultation will be sandwiched with time with a psychologist or a counselor because they're dealing with so much. There's so much going on. You know, their job is at risk. I've seen so many who have lost their jobs because they're saying they have too many sick days off. Their marriage is at risk. Their position in society as a woman is also threatened. So many times it's important to include someone to deal with the psychosocial aspect, also involving family members in such a consultation because they need to appreciate, because people sometimes talk about painful periods and some other, even women can brush it off and think you're just joking.
Yeah.
I don't feel any pain. Why are you needing special days off? Why are you needing special attention?
So endometriosis is really not good. Personally, the day I diagnose a patient with endometriosis, it's really a sad day. And then its treatment is also, especially when it comes to the laparoscopy, it's quite expensive.
Yeah.
So you're looking at an expensive treatment. This person may eventually need still fertility treatment, both of which are still very, very costly. But then on our side as clinicians, because endometriosis, what I've seen, the earlier the diagnosis, the better the prognosis, the outcome. But sometimes most of these diagnoses are missed. You find someone is being treated for PIDs, that's
Endometriosis.
yet it is endometriosis.
Yeah.
So enlighten us a bit on this really high index of suspicion.
So if you're a clinician out there, or you're a patient, or someone out there, just if you have painful periods, even if you have no challenges conceiving, just have those evaluated. And the best way is to see a gynecologist. That is the best way. See a gynecologist within your reach, have a full evaluation. Because as I said, with painful periods, the chances are 40 to 60% that actually it exists. There's so many people out there with endometriosis who have no pain.
Yes.
They're there too. But those with pain, especially the pain with periods that keeps happening, sometimes towards the period, during the period, after the period, high index of suspicion. If you add painful periods plus painful sex, that's nearly 80-90% chance that endometriosis exists here. So for a clinician who is a general doctor, if you have such a patient before you, link them up with a gynecologist. If there's a patient and you have these symptoms, have yourself evaluated. We are not saying that everyone with painful periods had endometriosis, but there's a high chance. You'd rather have it ruled out than waiting for when you reach the doctor and it is really so far gone.
Yes.
Yes.
Okay. So what else can cause painful periods, just so that the viewers can...
Yeah, so painful periods can result from having uterine fibroids.
Okay.
These are kind of like small non-cancerous tumors that develop in the uterus.
Okay.
We can also have painful periods as a result of infection. If you have some infection in your pelvis, you can have painful periods. Then lastly, there are people with painful periods without any cause.
Okay.
As something that is just happening from the beginning, it's just painful periods, but there's no apparent reason as to why they have painful periods. But that is like the smallest percentage. Only 20% of painful periods can be explained by anything else other than endometriosis.
Endometriosis.
There's always a high chance endometriosis is there, but we do not know whether it is severe endometriosis, moderate endometriosis. Because endometriosis is very funny. Sometimes someone has so much pain, but you do a laparoscopy, that's a camera test, and there's only a drop, just a dot of disease.
Yes.
Then someone has not so much pain, you do a laparoscopy or the keyhole test, and the disease is advanced. But all that is at the discretion of the clinician who's managing you. The best thing is to get access to the gynecologist, have yourself evaluated.
Okay. So what are some of these drugs that we use to treat the disease?
So one thing maybe we need to mention is endometriosis is a hormone-dependent disease.
Okay.
The youthfulness of women is mainly a product of estrogen. And most of these diseases like endometriosis feed off that estrogen. And that is why sometimes women will see a decline in symptoms as they go into menopause if they have endometriosis.
Okay.
And that's why it's not so common to find women in their menopausal part of their life with painful, periods. I mean, all kind of symptoms that indicate that endometriosis is actually there. So since the disease survives off estrogen, any kind of treatment that can counter estrogen is usually very effective. For example, combined oral contraceptive pills have a non-contraceptive role because they are able to counter the impact of estrogen and result in reduction of the disease burden. We have progesterone-only pills, which can also help reduce the burden of the disease by countering estrogen. We also have drugs like there's some injections that work on the master gland of the brain. So there's a master gland in the brain that controls most of the other glands that we have. And one of the controls they have is on reproduction. So there are certain drugs that work by working on the master gland to prevent reproduction by limiting those hormones in the blood, which the endometriosis spots are feeding on. So the main kind of principle of treatment is to limit, especially medical management, is to starve the spots of endometriosis from their much needed estrogen. And in a way, the disease burden will reduce and possibly the quality of life will improve and reduce the chance of recurrence.
Okay. So, as in terms of its, you've said sometimes the symptoms are severe and you do a laparoscopy, you find mild disease. And then sometimes the symptoms are almost silent, laparoscopy and severe disease. How important is that first surgery? Because I've seen clients who have undergone quite a number of surgeries. But how important is that first one?
So maybe just a bit of background. Surgery leaves scars.
Okay. And
endometriosis causes scars. So if you're going to perform the first surgery, you have to do it to the best of your ability because you're going to leave scars here. And the second, third, fourth surgeries become more difficult than the first surgery. The first surgery is the most important surgery for endometriosis. Indeed, if a patient is before the clinician and they have had surgery before, most doctors are not very likely to offer surgery again because repeat surgery doesn't have benefit. So the first surgery is very, very, very important. And what does that mean? In the right hands. There are doctors, gynecologists who are specialized in managing endometriosis surgery. I think this channel can actually have those kind of links for patients who reach out to get those kind of contacts to be seen, and for us, the other doctors that exist, to know when to refer such a patient, because the first surgery, as you've said, is very important. Okay. If the first surgery is not done well, you have introduced scar tissue into scar tissue. That makes the second surgery, first of all, the quality of life worse, second surgery worse, and the third surgery worse. So the first surgery is important, very, very important. And it's important that it is in the right hands.
Okay. Yes. So we're about to wrap it up. Can you, I know you've seen quite a number of patients with the disease. Could you maybe share a personal experience? One of the presentations you've had.
Yeah, so one of the typical presentations I had was a lady who I saw about 8 years ago. She had painful periods. She had her first surgery and then was put on some of the drugs that limit recurrence. Then 2 years later, she had a second surgery. And then she got married, but unfortunately couldn't have kids. And then had to do an IVF, which didn't work, and the second didn't work, and the third worked. And she was pregnant with triplets, but unfortunately lost the pregnancy at about 13 weeks of gestation. Pain got only worse. She has had other 4 surgeries done, some of them costing about 8, 9, 18 million, and still has pain. She's been in pain since she's began having her first menses. She's now, I met her when she was about 23. She's now 31 years of age, has lost her marriage. She still has no child. She's still in pain. A lot of pain that sometimes she has to use cannabis to numb the pain. and cannabis still fails. It is that bad. And many times, as a clinician, you feel like you're not helping the patient enough, but it's sometimes out of your own limits because you offer everything and endometriosis will return probably even more severe than it was. It's kind of those things that we really need to understand the context of when it happens, the issues surrounding someone's life. You need to manage an endometriosis patient holistically. Their marriage, their family, their work. It's very, very important. So I don't have any good stories for endometriosis. Even those who do get pregnant eventually sometimes report a return of symptoms that are debilitating in their lives. So it's one of those conditions that we need to address as a society, not just because of the fact that it's a disease, but its impact is very far-reaching beyond the patient who has it.
Okay. Personally, the presentation it's usually almost the same. Comes in with chronic pain, infertility, laparoscopies, severe disease. Some even come with diminished ovarian reserve. You almost can't retrieve any eggs because they have had these recurrent endometriomas. Then IVF, first IVF was not a success, second wasn't a success. Go to the third IVF, conceived, high-risk pregnancy, always in pain. 30 weeks, patient ruptures because of a previous adenomyomectomy. And then
had a uterine rupture.
Yeah, uterine rupture. So usually not really good stories. But there are also success rates with the disease.
Yes.
Personally, I think what needs to be done is, first, the community needs to understand that endometriosis is actually there. And when someone is complaining, periods are painful, it's not normal. Not all cramps are normal. Yeah, so I don't think women should normalize serious menstrual cramps that will need you to be admitted.
Neither should men.
Neither should men.
Yeah.
The partner should actually also understand. Yeah. So what is your parting shots to the women out there?
To the women out there, if you have painful periods, painful sex, or you have pain that you just can't explain, you've seen so many doctors out there, you've done so many ultrasound scans, but no one can pinpoint or give you some kind of relief. See a gynecologist near you, have yourself evaluated. You could be having endometriosis. And the earlier it is detected, the better your possible quality of life and outcomes.
Thank you, Dr. Anthony.
Thank you for having me on your channel.